If you're a nursing student on clinical rotations, checking lung sounds isn't just about putting your stethoscope on a patient's chest and nodding your head. You need to know how to listen to catch the dangerous abnormalities. Let's master the technique and the big 6 abnormal sounds for your next test. First, the gear. Always use the flat diaphragm of your stethoscope and press it firmly against the skin. Never listen through clothes, because that creates friction that sounds exactly like abnormal crackles. Instruct your patient to breathe deeply through their mouth. Breathing through the nose creates upper airway noise that corrupts your assessment. Make sure to keep an eye on the patient so they don't get dizzy or hyperventilate during the auscultation. And do not listen over breast tissue. Listen to at least 1 full respiration. That's a full inhale and exhale at each site. Always move in a side-to-side ladder pattern to compare right to left as you move down. Posteriorly, start at the apices and move down 12 spots while avoiding the scapula. Anteriorly, start from the supraclavicular space down to the 6th rib, also in 12 spots. Normal lung sounds are bronchial, bronchovesicular, or vesicular. Bronchial sounds are heard over the trachea and larynx. They are high-pitched and loud, lasting longer during expiration. Bronchovesicular sounds are heard over the major bronchi. They are medium-pitched and may have a brief pause between inspiration and expiration. Vesicular sounds are heard throughout the peripheral lung fields and are lower in pitch. If the lung sounds are diminished or aren't clear, then this is abnormal or adventitious. Let's start with fine crackles. It's a high-pitched, intermittent, popping sound at the end of inspiration, like Velcro pulling apart. It means fluid is accumulating in the alveoli and interstitial spaces, commonly caused by pneumonia or congestive heart failure. If it sounds low-pitched, intermittent, bubbling, or gurgling instead, those are coarse crackles. The lungs sound wet. Think of severe fluid overload from pulmonary edema or terminally ill patients. Raunchy are continuous, low-pitch, whistling, or snoring type noises produced on expiration and inspiration. Think of conditions that cause narrowing of large airways or mucosal edema found in bronchitis. Raunchy may clear or change when the patient coughs, while crackles don't. Wheezes are high-pitched, musical, or whistling squeaks, usually heard when the patient exhales. This is a small airway problem. The bronchioles are narrowed or constricted from asthma or swelling. A pleural friction rub sounds like a superficial, dry, grating, or rubbing sound during both inhalation and exhalation. It means the pleurae are inflamed, a condition called pleurisy, and it hurts the patient badly. Finally, stridor. This is a harsh, piercing, high-pitched crowing sound heard on inspiration or expiration. It's often so loud you can hear it without a stethoscope. This is a life-threatening medical emergency, meaning the upper airway is closing up from an obstruction or severe swelling. Do not leave the room. Call for immediate help. Master the technique, remember the cough test for raunchy, and treat stridor like an emergency, and you will absolutely ace your nursing school exams and protect your patients on the floor. Good luck on your exams and go help people.